Let me. We're recording. Okay, go ahead.
Okay. All right. Hi, I'm Kate. I'm a nurse practitioner at Overlake. I have a subspecialty in headache, and I was asked to speak to your group today about headaches. First, the talk was going to be a little more geared towards some of the new treatments that have come out and just how to treat in general. But then as we were talking about that this was for the senior center, I thought you guys might have more of an interest in when you should actually worry about a headache. Because headaches don't, luckily for most people tend to, their headaches get better as they get older. Not always, but the majority of the time, and the majority of my patients tend to be in the, well, generally between the 30s and 50s. Although I certainly have some 60s and 70s and 80-year-olds that have had headaches all their lives. But for the most part, especially in women, their headaches do get better as they go through menopause and as they get older. And it becomes a little bit more of the worrisome headaches that you get as you get older. Not that you can't get those when you're younger, you certainly can. And this talk kind of goes across all age groups, but I thought it might be more of interest to you than kind of what the new treatments are for migraine. So that's where this came from. And you'll have to, if you have interest in other things, please let me know if they have to do with headache. This is kind of my love. This is my thing. What I like to do is treating headache. So first, kind of what not to worry about. If you have headaches, you've had headaches all your life, there hasn't been a whole lot of changes in them. Maybe you're getting them a few times a year, a few times a month, once a week, but it's fairly consistent, then you shouldn't have to worry about it anymore, no matter what age you are. The frequency, the pattern, like kind of how they come on, if that stays the same, if the severity has stayed the same, those are things that you're kind of should be looking at if you have a history of headache, and whether or not, gosh, is this a headache that I should worry about? If things are pretty much the same, don't worry. That is not something you would have to worry about. But there are a list of things that we consider red flags in neurology as far as changes or something different about a headache that we do want you worried about, and we want you either contacting us right away or going to the emergency room or calling 911 about. And so I'm going to go through some of those red flags about headache that are more worrisome and kind of what you should do about it. Whether, gosh, this is a little bit worrisome, but you can just call your primary care doc and see if you can get in the next week or two to discuss it with them, versus this is really worrisome, you should call 911 and get to the emergency room on this one. So first one is the first headache of your life. Like I said, headaches are not as common as we get older. It's very common to have headaches when we're in our teenagers and into our 50s, but they don't usually start that late. So they usually start like in our teenage years, sometimes in our childhood, and even into our 30s. Anytime someone comes into me above that and they say that they've never had a headache before and all of a sudden they're getting headaches, even if they're pretty classic migraines, it still raises a red flag for me, especially if they get to be about the age of 50 and above. Then I really start getting a little bit more nervous. It may still end up being just a normal migraine or a tension type headache or some kind of primary type of headache that's not worrisome. But if they're getting up into their 40s, 50s and above, and they've never had headaches and all of a sudden start having them, it definitely raises a red flag. So what are we worried about when that happens? Really something like this, like a brain tumor. That's probably our biggest things. And it's the biggest things you're worried about too. If all of a sudden you have headaches, I think just the general public, if they've never had headaches and all of a sudden they do, that's what they're most worried about. And we are too in the medical field, but it can be a lot of other things. Sometimes something very benign and sometimes something also that's bad medically, but maybe not a tumor. So the things that we're going to start thinking about if you come in and you're say you're 61 and all of a sudden you're having headaches and you never have in the past, we're going to be thinking about a tumor, but we're also going to be thinking, gosh, could you possibly have a bleed in your brain? And we'll ask you more questions to try to tease that out. The reason that's important, all of these that they're important, is the type of testing that we do differs depending on what we're worried about. So say we're worried that it's blood. Maybe you've hit your head, maybe you're on blood thinners and you might have hit your head, but you didn't think it was that hard. Then we're going to think about getting a CAT scan, because the CAT scan is much more sensitive for blood versus an MRI. MRIs are great for almost everything else with the brain, but in blood in particular, we like to look at CAT scans. If you're over 55 and you're saying, gosh, never really had headaches before, or I've had headaches before, but they weren't that big a deal, and now they're always right here, right in my temple, and it kind of it hurts a lot, and it hurts if I push on it, and maybe you're having some vision loss, excuse me, then we're going to worry about something called temporal arteritis. And we'll do some blood work for it. We might send you off for a biopsy of that artery, and we're going to get you on probably steroids, because that's the best treatment for temporal arteritis. And if we don't treat it, then you can lose your vision. Other things we're going to be looking at is we'll get your vital signs. We're going to be thinking about hypertension or high blood pressure. That can sometimes be a cause of headaches, especially new headaches. And so obviously the treatment then would be to get that blood pressure down, however that might be. Sometimes when somebody all of a sudden starts having headaches, it's actually something more benign, like side effects to a new medicine. And so we'll typically go through all of the meds you're on. I'll often ask, okay, when did you start each of these, since I might not know you, that like if you're a new patient for me, and try to go through the timeline of when the headache started and when the medicines started. And medicines would include things like supplements as well, because once in a while supplements, especially, well, depending on the supplement and depending on the dosing, they can also cause headaches. They're not benign. We'll be thinking about things like chemical exposure or maybe carbon monoxide. That would be pretty unusual, but it is something that's going through our head as we're checking off the reasons why somebody might all of a sudden be having headaches. Stroke is always a concern. Usually you have other symptoms besides a headache, but it's certainly going to be on our mind as we try to figure out what needs to be done next. Many times headaches that are new or different, oftentimes they're more benign though too. And so we're going to be looking for things like a virus or some sort of upper respiratory infection, sinus infection, depending on where that headache is located and kind of what's associated with it, whether it's you're congested or you've got a fever or that sort of thing. Other big causes are things like stress. It's not infrequent for somebody to all of a sudden develop headaches right as they're going through something really stressful. And some people are very intuitive to themselves and they put it together, and other people don't. And sometimes you just need somebody to talk it through to figure out, oh, those two connect. You need to deal with your stressors anyway, but maybe even more so, maybe those stressors are creating this headache or somehow making my adrenaline levels surge enough that sets it off. Probably a key example for that, for a patient that I've been treating for about a year now, is a gal who I met. And as soon as I met her, she hadn't told anybody else this, but she had gone through a very particular physically and emotionally traumatic event. And the headache started right after, like within days. And she'd never had headaches before, and she's in her 40s. And so it's like, it's, even though her headaches very clearly fit the criteria that we need to diagnose her as migraine, the trauma was so closely connected. And it's been interesting because our treatments that we've been using, she's gone through many of our typical treatments for migraine, they're really not touching it. And as I keep telling her each time I talk with her, we really have to go back and deal with that traumatic event because that's stress. And she knows it too. It's just she doesn't want to it was so traumatic. She doesn't want to have to relive it, but she is starting to work with a therapist now. So I'm hopeful that the headaches will follow as she's able to process what happened. Anxiety can sometimes cause stress or cause headache. One thing in particular I was just thinking of that, like this morning, a couple of patients that I saw, they're clenchers. And with the more stress they get, the more they clench their jaw. And then their headaches tend to be a little different than their typical migraines, but go up to their temples. Sometimes it can go down to your neck too, if you're a clencher. And then go back up the head again. So looking at things like that, whether it's the anxiety or the clenching or the keeping yourself very tight, can certainly set off headaches. Sleep deprivation is a biggie for headaches, and then dehydration is one of the #1 things to cause headaches. And even if you haven't ever had headaches before, but all of a sudden your body's under a lot of stress, so maybe you're dehydrated, that could be a cause for all of a sudden developing headaches. Most likely, most of us in the medical field will still do a bit of a workup though. Might have you try to work on correcting that first. But I think anybody that's getting their first headaches and they're over the age of 50, we're probably still going to send you in for some imaging unless something else is really obvious, because we don't want to miss anything. Like I said, it depends. And if something else is more obvious, we might have you work on that first. All right. Next headaches to think about that are worrisome. Worst headache of your life. That is a term that we actually use in the emergency room. It even has its own abbreviation, which when I used to work with neurosurgery at Harborview, and I don't know, for some reason, it just tickled my brain somehow that it was of interest that WHOL stands for worst headache of your life. And it's an actual medical abbreviation that's used because there's a very direct correlation there with aneurysms and an aneurysm rupture. So if somebody has the worst headache of their life, if they call into the clinic and it's a patient of mine, and oops, there we go. If somebody, like say I have a patient and they have a history of migraines or a history of cluster headache, and they call in and they tell my nurse, hey, I've got the worst headache of my life, or that my spouse has the worst headache of their life. If I hear those words, it's like, I know they need to go to the ER. I'm not going to fiddle around and worry or think about this as a migraine, because those words go so closely with an aneurysm rupture. So if you're at home, you should call 911. If it's your spouse or loved one or friend, and they say, oh my God, I just got the worst headache of my life, and they can tell you, you call 911. Don't wait around on that one. Same thing with thunderclap headache. So a thunderclap headache is a headache that comes on very sudden, very severe. So it can be a thunderclap headache that is the worst headache of your life together, and oftentimes it would be, and those all immediately make us worry about an aneurysm rupture in your brain. So that's a headache that just comes on, bam, and it is 10 out of 10, never felt anything like this. So again, call 911. Get to the hospital. Don't mess around, and don't call your provider to find out what to do if that's the type of headache it is. This is what we're worried about. So let's see, I think I can use this. So, well, actually the arrow kind of points to it. So this is blood in the brain. This is a CAT scan. This is somebody that came into the emergency room with the worst headache of their life, and they immediately, hearing those words, the emergency room staff is going to get them in for a head CT because they're worried about an aneurysm rupture causing blood up there, causing that pain. And the white area then is the blood. This is a picture of a CTA. So it's a CAT scan with an angiogram, which basically is a scan that looks at your head, at the blood vessels, not the brain tissue. And so that arrow is pointing to the big aneurysm that's up there. So you would expect, if you went into the emergency room with the worst headache of your life, thunderclap type headache, that these are the kind of tests that you'll probably get. You might also get a lumbar puncture. If there's somebody comes in and say the CAT scan is not real obvious, that there's blood there, but you have this, never really have had headaches before, and all of a sudden you have a 10 out of 10 headache. I've never felt this kind of pain before, and it came on super suddenly, like out of nowhere. That kind of history keeps us very concerned about an aneurysm, and you can have such a small amount of blood sometimes that with the aneurysm rupture, we call it a leak because it's not a full out rupture, that sometimes they can't see the blood on the CAT scan. And if that happens, they might do something like they might do a lumbar puncture. The reason is, let's see, I think I got one more. Yeah, so that needle, which you can see here, it goes in between your vertebrae in the back, and it goes into where your spinal fluid is. And we drain off a little bit of spinal fluid. If that spinal fluid has blood in it, then there's a very high likelihood that blood is coming from a rupture in your brain, and it might not have been detected on the CAT scan, but you can see it in the spinal fluid. And you might think, well, gosh, wouldn't putting a needle in your back or anywhere in your body for that matter produce a little bit of blood? And you're right. So when we do a lumbar puncture, we actually draw 4 different tubes of spinal fluid. And the first one, we expect to have blood in it, or a little bit. Sometimes we call it a clean tap, or what's the other word? Oh, I remember we used to use the word champagne tap at Harborview. And that would mean it was just a pristine tap and there was absolutely no blood in that first tube. And that could kind of give you bragging rights that you didn't have to, poke around at all. That would be nice for everybody, not just the patient, but the provider likes those too. But that first tube might have some blood in it just from the tap itself. But by the time you get to the 4th tube, you shouldn't have any blood in the vial that we're collecting. And so if it still has blood in that one, then we get real worried that there is some blood going on, or there has been a bleed up in the brain. And then we'll do more of a closer look and probably go back to that the CTA, that CAT scan angiogram that I was talking about to look for an aneurysm. Sometimes you can have bleeds in your brain and it's not from an aneurysm also. Like somebody can have a high blood pressure surge and just there'll be a weakening in the blood vessel somewhere that'll bleed. But these are the worrisome things. So what else could like a thunderclap headache be? I didn't put what else could a worst headache of your life be, because it was like, well, actually, I don't know if there really is any. I mean, somebody could, obviously, we all can have the worst headache of our life in comparison to any other headache, but it really not be that bad. But we're probably not going to call it the worst headache of our life. There really isn't anything else that one could be. So it's going to be very much on the provider's radar that it is a bleed in the brain. But a thunderclap headache, there actually are a couple other normal may not be quite the right word, but there are a couple of other primary type of headaches that aren't worrisome, that can look like a thunderclap headache. Probably the most common one is something called a primary exertional headache. And that one gets the same workup that a thunderclap headache is. But it should be negative, as in there shouldn't be any blood in the brain, there shouldn't be any aneurysm showing, that kind of thing. Or if you did a lumbar puncture, no blood in that last tube. And it is a headache that comes on after exertion. Now, an aneurysm rupture can also come on after exertion, so you don't want to make yourself go, oh, well, I was lifting these weights and I was kind of pushing myself and got this horrible headache, but Kate said, there's this thing called primary exertional headache, so I'm not going to worry about it. Please don't do that. If it's never happened before, do worry, do go to the emergency room. We want to rule out that it's something bad before we ever would say, oh yeah, I think this is just primary exertional headache. The treatment for that varies. Basically, we use different kind of preventative treatments and try to slowly increase your endurance and not have you repeat those activities for a little while. But that is a common story also with aneurysm, is that somebody was working out. What else? Just, yeah, exertion. Orgasm is actually a potential. We would frequently, when I worked at Harborview, that would be that somebody would say, yeah, I was having an orgasm and all of a sudden I got this worst headache of my life. And sure enough, an aneurysm had ruptured. Cluster headache is a little different in that it doesn't tend to have a trigger like that, like working out, but it does kind of come on a little more suddenly than like a migraine. So migraines tend to come on and they'll take usually 30 minutes, maybe an hour, sometimes even a few hours before they reach their worst intensity. So they come on slower. Cluster headaches tend to come on fairly strong. They tend to be kind of around the eye, maybe in the temple. They put you to the ground. Usually people are completely disabled during a cluster attack, but then it just goes away after about 3 hours. Well, actually anywhere from 15 minutes to 3 hours, boom, the headache just is gone. Whereas an aneurysm rupturing, when it just clears so easily and quickly. At the same time, again, if somebody came in for the first time with what sounded like cluster headache, had never really had headaches before, had never really been worked up, probably most of us will still keep that on our radar that this could be something more worrisome, and you might get it, very well might get imaging done of your brain. All right. Next type of headache that we worry about is a progressively worsening headache. So this is one that, say you've had headaches all your life and all of a sudden you're noticing, gosh, I used to get headaches, you know, a few times a year, and now I'm getting them a few times a week, and now I'm getting them almost every day. Sometimes the severity gets worse with this kind of headache, but sometimes it doesn't. And so people will be like, yeah, I wasn't really worried about it because they were still pretty mild, but they just start happening all the time now. I'm waking up with them every day. That's a common thing we'll hear, and we get the little red flag again pops up and we start to worry. If that should happen, if you should have headaches like this, or a loved one has headaches like this, it's not something you need to call the emergency room for, or go call 911 or go to the ER right away. But you really should call your primary care provider and get in for an appointment sometime in the next week. And why? So there's a potential for a lot of different causes with this type of headache. Hopefully it's something very benign, like maybe some poor lifestyle choices, like been drinking red wine every night and, you know, all of a sudden I'm having headaches all the time. I wonder why. Or been very, very stressed, or a medicine change and that was creating headaches. Could be something a little more worrisome, like sleep apnea. Especially if you're all of a sudden waking up with headaches every day, that's going to be on our radar as far as a cause, is maybe you have developed sleep apnea and you're not breathing very well while you're sleeping, not getting good oxygen to your brain, and thus waking up with headaches. Another one can be hypertension or high blood pressure. Most of the time, high blood pressure is a very silent killer, I think is the word I wanted to think of. It's just a silent diagnosis where you don't feel differently with your blood pressure up, and you would never know your blood pressure was high until somebody checks it. Not that that means it's okay, it's definitely not. But headache is one symptom that can sometimes come from somebody's blood pressure running high. It also can be a progressively worsening headache can be a sign of something even more worrisome, like those first pictures of the brain tumor. Sometimes, I'm trying to think of, the tumor is kind of the big thing we worry about. Things like hydrocephalus, which is extra fluid on the brain, that can sometimes cause a progressively worsening headache. Stroke could, but usually that would just be a headache that just comes on. And the reason you'd want to come in and see your primary care provider versus just calling them and kind of trying to work it out over the phone is that they need to see you to be able to do a good neuro exam. They're also going to want to ask you a lot of different questions about some of these things I was talking about and order imaging. But the neuro exam it's something you could do virtually, like on a video like this, but it is hard because there's a lot of subtle pieces of the neuro exam that you really need to be able to see up close, like how your pupils are changing or changes in your face as far as strength goes. Sometimes that's not real obvious on a video. Checking things like your balance is you can do it on a video, but it's not exactly the best. So most likely your provider would want you to come in and actually do a good exam for this one. Right, other things that you should call about or go to the ER, actually, sorry, go to the ER on these. If all of a sudden you have headache and you're developed other neuro symptoms, even if you don't have headache and you develop any of these symptoms, you should go to the ER. So things like slurring of your speech could also mean jumbling of your speech. Like maybe it's clear, but it makes absolutely no sense. Your loved one becomes confused, doesn't know what's going on, doesn't know who you are, where they are. If you develop a change in your vision, like double of your vision or loss of vision. A loss of vision meaning parts of it's gone or all of it's gone. Those are not things to call about. Those are things to just get into the emergency room for. If you develop weakness on one side of your body, whether it's your face, your arm, your leg, numbness on that side, those are things, again, even if you don't have a headache with them, you should get into the emergency room because we're worried about stroke. If you develop a headache and it's got a combination with fever and a stiff neck, those are other things you'd want to go to the emergency room for, because then we're starting to worry about meningitis. All right, the last thing that's a big red flag in the world of headache, the world of neuro, is fainting or a seizure with the headache. So these are always worrisome. If somebody that you know or yourself should develop a headache and then faint or have a seizure, you should be calling 911 and getting them to the emergency room right away. For the seizure, that generally speaking, if it's a first-time seizure, you should just always call 911 and get medical treatment, and they can work them up because that's not normal. Obviously, if somebody has a history of that, they faint all the time or easily anyway, or they have a history of seizures, you don't have to call 911 for each one. But anything new like that, it's a very, very good idea because it can mean something bad is going on in the brain, whether a tumor or an aneurysm rupture or whatnot. All right, that was actually a little bit shorter than I think I was expecting, only about 30 minutes. What kind of questions do you guys have about this?
I have a question about a peculiar feeling I have, and I don't know if you call it a headache. It's more like a flat head, but kind of here. And it's just been, maybe the last month, and it's every now and again. What would you call that? Do you know what I mean by, I have migraine and it's not that sort of pain. And it's not really pain, it's more like a sort of a slight pressure, I guess. Okay. I would describe it as.
How long, does it last for very long?
No, 5 minutes, I would say at the most. It's just sort of an odd feeling I've never experienced before in my life, and that's why I can't say it's a painful headache.
Yeah, a headache or not. That sounds like one that I'd be worried a little bit more about something else causing it. Yeah, like you said, it doesn't sound at all like a migraine, and you have migraines, so even more so But if that's one of those ones that I'd want, your primary care would want to do things like checking your blood pressure, because sometimes the blood pressure headaches can kind of be like that where they're kind of not something that you worry about, but they come on and go away. Trying to think of the other causes as far as a headache like that. Sometimes stress ones could do that. So kind of paying attention to, gosh, are these happening when I'm more anxious or when something is happening? It's a little different one, like you've already noticed, but it would be one I would definitely talk with your primary care about, and because they're probably going to want to do definitely checking your blood pressure. That would be kind of top on their list, I'm sure. And then kind of going through to see if something else could have caused it. But
my blood pressure is always normal.
That's good.
And I'd say I was stressed with this COVID-19 because I'm 75, so we are self-isolating, my husband and I. So would you suggest then I just call to begin with because we don't particularly want to go?
Trying to stay out. I would, and just let
Yeah.
them know, and so they can kind of sort through, because your primary care probably knows you pretty well.
Yeah.
And they can kind of sort through, gosh, is there anything else? And then, and in the meantime, you pay attention to
Yes.
when it comes on. Could it be stress? I mean, is it happening? And do you check your blood pressure at home?
Occasionally, yes. And it's always been normal.
You could check it though when you have that and just see.
Oh, yes. Okay.
That's what I would do, just to see if that, because maybe it's running normal most of the time, but it spikes once in a while. Of course, thinking about it is going to make your blood pressure go up a little bit too, because it always does. Just all of us do that. But I would, kind of pay attention to those things as well. Because usually, like if it's a medicine change or some kind of chemistry imbalance, that wouldn't just happen for those short periods of time so intermittently. It's usually a little bit more constant. Or, you know, if it was, say, something bad like a brain tumor, again, it wouldn't be such a short period of time and so episodic, kind of, not so constant, or not a little more constant than 5 or 10 minutes. So that's a good sign. But I certainly would want to make sure it wasn't something bad, like having a little hypertensive blood pressure spikes, that kind of thing.
Okay.
Yeah.
Thank you.
Definitely call them though.
Yes. Okay. Thank you.
So Kate, this is Catherine. Would it be okay if you stop sharing the slides so that we could see everybody more clearly?
That
would be great. And it looks like Joanne, once you do that, Joanne has raised her hand.
All right. Hello.
Hello. Kate, I was wondering if you could talk a little bit about painless migraine.
About what?
Painless migraine.
Oh, yeah, I can. So are you talking about like an aura that you get and then you don't get the migraine pain? Or are you talking, because there's also, I have some patients who we can get their migraines under really good control, but they can still tell their body's trying to have them. Particularly some of my patients that are on Botox for their migraines, they'll report back that, I can tell my body is still trying to have a migraine, but because I get light sensitive and noise sensitive and nauseated, but I don't actually get the head pain. So that would be kind of one type of painless migraine. But I think what you might mean is more like an ocular migraine, or just that you get the aura but not the migraine with it. Does that sound familiar?
Vision narrows,
and
everything's kind of fuzzy, and
then it improves, but then you never get the headache that you're supposed to get. Yeah, that's called, well, a lot of people have different names for that one, but usually that one's called like an ocular migraine, or I've heard the painless migraine, or I've heard migraine without aura, without the headache. We got lots of different terms for it, which makes it more confusing. So when that happens, like when somebody comes in and they're having, say, a vision change, and maybe it lasts for 20 or 30 minutes, sometimes it's a loss of a vision or tunneling of their vision, or other times it can be like squiggly lines going through their visual field, or lots of sparkly dots. But it's episodic, meaning it happens and then it goes away again. And sometimes it kind of comes on and gets more severe and then goes back away. Sometimes it just comes on and just full force and then goes away. But that episodic piece is always the part that makes everybody go, could this be? But we usually, or at least myself, I shouldn't say for everybody, typically though, we'll go ahead and get imaging of your brain just to make sure there isn't something bad going on. And sometimes I will even get something like an EEG if it's not super classic for a migraine or an ocular migraine, because I'll be a little bit worried maybe they're having seizures or something. And so I'll get an EEG just to make sure that they don't have abnormal brain waves going on that could indicate that instead of aura, that these are actually little seizures. It's so much easier when it's just the aura comes on and then you get the migraine after, because it's like, okay, there you go. It's migraine with aura. But when you only get the aura and not the head pain, it always deserves more of a workup to make sure that that really is what it is. Basically, your brain is doing the same thing as it does with a migraine. And there's lots of different chemical processes happening, and you just, for some reason, and we're not really sure why, you don't get the pain part of it. And we don't, yes, unfortunately, we don't know why yet. And it's pretty rare. I mean, not a lot of people get them, but it's certainly out there. I certainly have a lot of patients with them, but I do headaches, so that comes without saying, I guess. I also have a lot of patients with migraine without aura, migraine with aura, and then they also will occasionally get the painless migraine or the ocular migraine. You could also, I guess I should say, usually it's going to be a visual thing, like you mentioned, but it can occasionally be like numbness and tingling in the face or down the arm, down the leg. You could even get some speech difficulties, and then even more so, we'll do a complete workup to make sure, gosh, this isn't little strokes or something, or seizures, and we'll make sure if everything comes out clear though, and it follows kind of a time frame that would sound like an aura, you just don't get the headache. That's what the diagnosis ends up being. So it's kind of a diagnosis after you rule everything else out.
Okay.
Does that make sense? Or did I answer what you were?
Yeah, that makes sense.
Okay.
Thank you.
Yes, you're welcome.
I was going to ask, basically, you took the words right out of my mouth, because I was going to ask about the ocular migraine. Because I've had them, like, they're so sporadic that I don't even know how I could get it checked out, because it wouldn't be there when I went in to get it checked out. One time my primary care doctor said, why don't you keep a log?
Mm-hmm.
And then it happened like once after that, and then it didn't happen for 6 months or 9 months or something. And I just, like, it's been going on so long that I don't worry about it anymore.
Yes.
I don't know if I should be worrying about it or what, but it never turns into a headache.
You're right, though, because that's the key, is that you keep having them and they're pretty much the same and they're kind of episodic. If it was your first time, though, ever to have it, that's when you get the workup. But if you've had it several times and it's like, okay, I've had this, all my life, or even, I mean, I guess I would worry if somebody came in, they'd never had them, but they'd had 10 of them in the last year. With that kind of history, I would worry. But if it's been going on all their life and it's pretty sporadic like that, I wouldn't worry. And I wouldn't have a lot of worry if it had been 10 times in the last year, but I would do more workup than I would if it had been all their life.
Yeah, I think she was trying to figure out if I was having like a lot of them in a row or something, and then it just faded away. But I sometimes when it happens, I get the sparkly thing,
Mm-hmm.
and I think, what caused that? What did I just do? And usually I think I have the feeling it's something with my eyes, like looking at the computer too long, or
Yes,
or changing what I'm looking at, or so. I just can't pin it down.
it can be. Checkerboards are a big one for setting off aura, or like visual patterns, like a checkerboard that's kind of this repeating pattern. I used to work with a neurologist that she could set off her aura by staring at a checkerboard. And she was really into research on migraines. And so she would oftentimes use herself as the model to see what changes were happening in her brain during the migraine. And so she would set off her aura and then jump into like a PET scan and see. And that's how we learned a lot, was by people that could trigger their own, because it made it so much easier than to do testing on them during the event. But you're right.
I think it when you said stare, I mean, I think that's the thing that I think does it for me. Like if I'm looking at something intensely too long and then I must be setting it off myself.
Yeah, you might be. You know, there's a couple companies that make these glasses that are for people with migraine, and they have a tint on them. And one of them is called Theraspecs, Theraspecs. Anyway, they're on their website. They have a whole bunch of different hints on how to change your computer screen and your phone and just like distancing from the computer screen to help reduce migraine triggers. And I've actually taken it and put it on my regular instruction sheet for the last few months, because especially with COVID, people tend to be on their computers a little bit more, and people that were maybe working in an office all of a sudden are working from home, and they're on these laptops and they're doing this kind of thing, and they're not set up with good ergodynamics. And so their little checklist is actually really pertinent for anybody that gets headaches. But yeah, if you want to check that out, they're called Theraspecs, and they're just, the company makes glasses that are great for people that get a lot of light sensitivity or that the bright lights trigger their migraines. So I'll refer patients to them sometimes to get their special glasses, but they also have a lot of really good educational information about, especially geared towards lights, and how to change out screens, that kind of thing, and reduce the blue light, which can be really helpful for people that trigger migraines that way.
Yeah, I hadn't had one for months and months and months. I can't even remember, but I've had maybe a couple of them since I've been locked up for 130 days. This is my 130th day.
And you're not counting, right?
And I'm positively sure that I'm causing them, but I just don't know what I'm doing. But
yeah, you think you're on the computer more since you're locked up?
Oh, definitely.
Yeah.
And my phone.
Yep. And then doing the whole, I got my phone in here and kind of doing that thing.
Yeah.
And the phone, they have hints on there too that you can go in and change settings to reduce that blue light. So you may want to check them out. I definitely would if I was noting that I was having increased headaches, or just the aura, because you can just be, for you, just setting off the aura piece, the ocular.
But is there something that's going on with the blood vessels when this happens? Yeah.
Yep. So a lot of different things are happening. We used to think migraine was only blood vessels, that it was just this inflammation and kind of the blood vessels got dilated. And they do that, but now we realize that's kind of after these different chemical events start happening in our brain. And the cause of the blood vessels dilating is from these chemical reactions. So our brain is already a little more sensitive if we get migraines. We're just wired a little bit different. And so surges in different chemicals can set off our migraine generator. Basically, it's in our trigeminal vascular system, which is kind of part of our brain stem. Anyway, that gets set off, and then pretty soon there's all these other chemical changes, and then the blood vessels get inflamed and dilate, and that's when the pain comes. So you might not actually be getting some of that since you don't get the head pain, but you are getting the chemical changes. The other thing and they found this by some of my old colleagues' research with aura, because she still is particularly interested in aura or the ocular migraines, is that when you get aura, you actually can see these changes march across your brain if you happen to get into a functional MRI at the time or a PET scan. And the blood vessel or the blood vasculature, we call it cortical spreading depression, but basically you don't get as good a blood supply as it marches across. It's like this decreased blood supply that marches across the brain. It's very, very interesting. But that happens with aura. So yeah, I don't know. That might be more than what you wanted to ask, but I think it's interesting.
I want to ask all that.
It's very intriguing.
Yeah.
All right. Any other questions?
If there's no one else that wants to go ahead of me, I just wanted to ask about, and maybe this is the chemical thing, but I got my first migraine when I was 14, and it was with an aura, and I started, and I hadn't started my periods, but after that migraine, I did start my period. Had them occasionally, but not very badly. And as I've got older, they've become less, and I don't really get them anymore. So that's me. And then there's my brother who had them. I don't know, maybe since he was 2, and he still has them, but I guess he's got. He lives in the UK, so you know we don't talk about it much. But he was taking the tablets to prevent them getting a lot worse, or I'm not quite sure of that, but. So I wondered about the difference in those two, just out of interest.
Yeah, well, good question. So what I was talking about at the beginning about most people's headaches get better as they get older, especially after the age of 50. That really was more about women, not men, unfortunately. Because women, as they go through menopause and their hormones die back down, oftentimes their headaches get better or go away, which is awesome, unless you happen to be 20 and you're getting migraines all the time from your hormones. Then it's not so awesome because you got a long time to wait. The men actually, up until puberty, boys have just as frequent of boys are diagnosed with headaches just as often as girls. They have the same frequency as far as getting them. But then once we hit puberty, then the females take off, and females predominantly are the ones with headache more often. So for your brother, he may get lucky, and hopefully through lifestyle changes and meds and all kinds of things like that, his headaches will get better, but he does not get that advantage of going through menopause because his hormones aren't going to do that like ours do. So his headaches are they're not going to go away on their own, basically, whereas a woman has a chance that hers will just go away once she hits menopause and the hormones settle back down. So,
right. Yes.
Yeah. You might not want to tell him that. I don't know.
No,
That might be depressing. I don't know.
I mean, I get the impression that they're not as frequent as they used to be. But so he's 65 now.
Okay.
But so I'm 10 years older than him, and I tended to kind of look after him a lot because we had a business that my mother ran, and they were extremely frequent, and he vomited with them, and it was from when he was a baby, you know, but then that would make sense for as far as I'm concerned, because mine didn't start till I was 14, and then now they've practically disappeared. Yes.
Yep. And he may have hopefully, besides the medicines that he's taken, he's probably started to figure out some of his triggers over time, and probably has made some changes to his lifestyle, like staying better hydrated. And if red wine is such a big trigger, maybe he avoids that if it triggers him, or getting good sleep and routines, that kind of thing. He's probably started to figure it out, even if he isn't consciously thinking about it. So that's good.
Okay, thank you. That was, that's interesting.
Good.
I'm glad I asked that.
Yeah.
It's just nice to know, the difference. And
it's nice to know that it's normal too.
Yes. yes.
Because sometimes we sit there and think, oh, geez, maybe he's, I don't know, we worry about things sometimes, and until we ask or find that information, it's like, oh, I didn't even, yeah, I don't have to worry about that anymore if it was kind of sitting in the back of my mind. So.
Thank you.
You're welcome. Any other questions? Anybody being shy? I can't tell if is there just, oh, there's a few of us. I
There I
think
am.
my computer wasn't showing all the pictures, all the people, but.
So I have a question, Kate.
Yeah.
About treatment. And I hear maybe just getting extra sleep or drinking water might work depending upon the cause. But, and I don't get headaches that often. I don't remember last time I had one, but I know that often when I do, the first thing I'll go for are the aspirin or the Tylenol. So I was just curious as to what are some of the better options or treatments what we should consider, or is nothing an answer as well?
Yeah, I mean, it depends. If it's getting in the way of your functioning, then I would say treatment is a good idea. I don't think anybody should sit there and suffer and not be able to live their life and do things if they can tolerate the medicine. If Tylenol and aspirin though work, then totally that's okay. Kind of a step up from that is things like Excedrin. Although with Excedrin, I always caution people because if you're taking it very often, it can lead into something called rebound or medication overuse headache. And pretty soon you start getting more and more and more headaches, and your brain gets more sensitive and it starts firing off much easier. But if they're pretty infrequent, you're totally safe with Excedrin. But if you're getting headaches that you need to treat like that more than once a week, you probably shouldn't be taking Excedrin for them, because it doesn't take much. It just takes a little bit more often than once a week that you can set that medication overuse headache into cycle. Then there's lots of, there's good lifestyle stuff. So I'll frequently tell people, besides your treatment, your medicine, do things like put ice on your head and your neck. Sometimes we've found warming up your hands and feet at the same time can work really well, but that's only if you're in a situation where you can actually kind of lay down and get some hand and feet warmers on and ice on. Drinking about 20 to 40 ounces of water generally helps most people, because many people are dehydrated when they get a migraine. There's a really nice correlation with that, or bad correlation really, but they are correlated. And there's some other little tricks, like I have some patients that are able to do things like give themselves a brain freeze, like drink a slushy type drink, and they stimulate on the roof of their mouth your sphenopalatine ganglion nerve, which sits back above the roof and back. And if you stimulate that nerve, you can sometimes break a migraine. And I have several patients that are able to do that on occasion, but that isn't always convenient either. But there are tricks that if you're kind of don't have anything else, there are things to try. Then things like naproxen and ibuprofen, I would say, are a nice step up for most people from the Tylenol, aspirin. And then you start getting into more of our prescription meds. The most common ones used prescription-wise for migraine are called the triptans, and that's things like sumatriptan, rizatriptan, amlodipine. There's 7 different ones. When they were new, they were called things like Imitrex and Maxalt and Zomig. So more people are familiar with those words or those names. Migraine specific, that's what they were made for. And they work on several different parts of the migraine versus just covering up the pain like the over-the-counter meds do. And they've been out since the 90s. They've been around a long time and really very safe, but they don't work for everybody, and sometimes they'll have side effects. They do cause vasoconstriction, and the FDA has put on their label, like way back in the 90s, that if you had a heart attack or a stroke, you shouldn't take these meds. Really, over time, most of us in the headache world have realized, studies done on it, they don't cause that much vasoconstriction. They're probably safe, but they're always going to have that label on them, so we always have to use caution. And I'll usually have my patient ask, or I'll ask her cardiologist, like if they've had a heart attack, before saying it's okay to use it. But I will say most of the time the cardiologist does say yes. So it's kind of interesting because there really isn't that much vasoconstriction, but it's good to do that double checking. And then just this last year, 2 new families came out of meds for migraine that are specific. And so that's kind of exciting. Neither of them cause the vasoconstriction. So that's nice. And they treat a little bit differently. And then we also have a whole bunch of different devices. There's 4 now that are used to treat headache without a medicine. So one of them is one that you put on your forehead and it stimulates the nerves that come out through here. One is one that you give a little magnetic pulse to the back of your brain, like 3 pulses, and then wait 15 minutes. And if the headache doesn't go away, you give yourself 3 more. One is one that you put up to your neck and stimulate your vagal nerve for a couple of minutes on each side, and that breaks the migraine for some people. And then the latest is one that came out that's you put on your arm. It's called Nerivio, and it stimulates the skin, sends a signal up to the brain, and shuts down the migraine. So that's kind of exciting. The downside to the devices is that most insurances don't want to cover them, but the upside is they don't tend to have any side effects.
Right.
So there's actually, there's lots of different steps. If you can get away though with things like Tylenol and ibuprofen, I would do that. I wouldn't, if the headache or the migraine is getting in your way of functioning, that's a problem. And we have lots of different tools to not let it do that, or not let it do that for very long. So I don't know. I'm a big advocate for figuring out something that works well for people so they can keep living.
Great, thank you.
Yeah. Any other questions? Now, so Patricia, where are you? I see in your background, you have an amazing rack in there. Are you in your office?
Oh, I am in my home office, yes.
Oh, funny. Well, they got me in the conference room here at work. So I didn't know if I was going to be in here or in my exam room or in an office. So it was better than probably some of the backgrounds. I don't know. All right. Well, thank you.
Thank you.
Yeah, if there's not any more questions, but yeah, let me know too if you ever need, especially with headache. That's kind of my thing. But I think all of us here enjoy talking to the community and kind of helping give some health information. It's fun. It's kind of what we're about.
Very informative. Thank you.
Good. You're welcome.
Thank you so much.
Yeah, thanks so much, Kate.
All
I
right.
really appreciate it.
Thanks. All right. See you later.
All righty.
Okay, bye.